And I would like to welcome Mr. Tim Hazelett to our program this morning. He holds a Bachelor of Science degree in biology from Marshall and is a lifetime resident of Huntington, West Virginia. As a Chief Operating Officer of the Cabell Huntington Health Department, his responsibilities include budget and finance, operations, logistics, buildings and grounds, training and development, and community partnerships. Prior to this appointment, Tim served as a sales rep and a district manager and regional director for a pharmaceutical corporation. Areas of work include strategic planning, organization and territory alignment, product launch and marketing, management, leadership, and communication. He has been in business management for 20 plus years. As a lifetime resident of the Huntington community, he serves as a member of the Huntington Rotary Club, a member of the Marshall University Internal Review Board, Medical, and is involved with many community coalitions focused on improving the health and well-being of our community. Wow, that's a great resume, and you've got a great background, and we're thankful to have you. So good morning, Mr. Tim Hazelett. We're going to turn it over to you.
Great, thank you, Elizabeth. And please call me Tim. Several of you on here I recognize and have had interaction with. Good to see you again. We're going to have a conversation this morning. I'm not going to speak or talk. I do have a PowerPoint presentation. We're going to try to stay very focused on the response that our health department has contributed to this community from a COVID-19 or SARS-CoV-2, whichever you want to use. We make sure that we use the appropriate terms when we speak about this. One of the things that I want to share, and I'm going to share it before I get started, I'm going to share my screen here in just a second, but we're doing a little, it's sort of a Facebook, just kind of a fun little thing to do where we're highlighting employees of the agency. One of the questions we ask is, what do you want the community to know? And we get various responses for our employees, but I am here to tell you 100%, and I stand behind them at the highest level, that the staff of the Cabell Huntington Health Department is passionate, committed, and my opportunity is more of getting in their way than anything that they do in the field. I'm going to talk about some of their responses. When you're dealing with a COVID-19, a novel coronavirus, as we refer to it, which novel meaning new, and something you don't know a whole lot about, this staff has performed admirably, and they have performed admirably in going on upwards of about 18 months. This has been a very long pandemic. We can't see the end of it yet. We've got some models that are telling us certain things, but this staff has performed at a level that is just, I'm in awe of, and it's fantastic for me to even be associated with them. So I am very pleased. I'm going to share my screen, and we're going to talk a little bit about the COVID-19 response. And we're going to talk about these 5 areas: the community testing, case investigation and contact tracing, call center, community education, and then we're going to get into vaccinations. And these are going to overlap as we go. You're going to hear me speak from a chronological standpoint. So when we look at the COVID-19 response, the biggest thing that we have done, and what has been extremely successful in Cabell County as well as the city of Huntington, is our community partnerships. And that's one of the things that myself, along with Dr. Kilkenny, have fostered through this pandemic. We went into what we call Incident Command on March 2nd of 2020. And what Incident Command essentially stands for is a command structure that is broken down into 4 specific areas, and then each specific area has a very, very focused responsibility. Dr. Kilkenny is what we call our incident commander. My particular role is finance and administration. We also have clinical response and logistics. So those are your 4 areas that we focus on. And under those is a number of different little strike teams, focus teams, assistants. And when we operate in that realm, what we do is set up incident objectives that we try to accomplish on a time frame basis. And that could simply be a 24-hour period, a 12-hour period, it could be a week. Just depends on what the situation needs. With this virus, we have established our time period of 7 days. So we meet every Monday morning. We have 3 specific meetings, one with the community partners, one with the planning team, and one it was a situational report from all the various partners. When I say the first one is the partners, that's to establish the strategic objectives and partnerships. So when we started this novel coronavirus, we didn't have a whole lot of tools. 2 things. We didn't have a whole lot of tools, and we didn't know a lot about the virus. We had we obviously followed some CDC recommendations as well as the medical science behind it. And a coronavirus, normal, a flu is a coronavirus, a cold is a coronavirus. So you have to establish what you're dealing with. Most of those are transmitted through aerosol droplets or touching hands, infected objects, doorknobs, light switches, shaking hands, hugging, getting close, all of those things. So we really went extreme on this, and isolated social distancing has become a normal word that you'll hear, and I'll tell you why. Masking, washing your hands. We went back to what we call public health 101, because we didn't have an intervention. We didn't have a pharmaceutical intervention. We didn't have a vaccine intervention. It was simply a physical intervention that we had to implement to make sure that we were fighting this virus the way we need to fight it. So that's where your social distancing and your masking. Why was there a controversy in mask wearing when we first started? And this is one of the biggest challenges we had from March to April, May, and up into June and around the middle of July. This was a worldwide pandemic and resources were depleted. That further hinders our response because now our toolbox is even less. So the reason that the mask controversy started is there wasn't enough masks to go around for the medical personnel to treat these individuals. When everybody started buying up the masks, you can't put your medical personnel in harm's way without the appropriate tools. And we've seen what we've seen first in December when this coronavirus COVID-19 was discovered, is that a lot of medical personnel were contracting the virus, and many of them were dying, and that now leads to a significant impact on your healthcare system. So we moved along into the about the May-ish, June-ish timeframe, and we start developing tests to see if we have a positive test, a positive coronavirus. Testing supplies were very, very limited. There's 2 types of tests. There's an antigen test and there is a PCR, polymerase chain reaction test. PCR is your most accurate test. So we had to develop a test. So a test was developed. The antigen test, when they first came out, were not very strong at all, to be honest with you. Actually, we chose not to use them as an agency. You were getting positive or negative rates at an alarming rate when you knew you had a positive. It wasn't consistent, and it wasn't strong enough to cause any kind of intervention. So the PCR tests came, and those were taking upwards of several days to even process. Combine that with a number of individuals who needed tested, and you suddenly overwhelmed your resources right out of the gate. So when we first started, you only tested individuals that you had a very, very strong suspicion who were positive. So we started testing, and then we overwhelmed the testing resources. Then we couldn't get the testing supplies. We couldn't get the reagent to do the testing. So another challenge is now in front of you. So now what do? Well, we just had to go back again to symptomatic identification and trying to mimic what we're seeing from a symptom standpoint. And generally when these individuals contracted the virus, you've seen everything from asymptomatic to death with this virus. The ones that were concerning to us are the ones that showed the most symptoms. You know, there's nothing I can do about an asymptomatic person without a test. So that created a big issue. So what we did right when the testing issue started is that's when we started our healthcare system partnership. And that is when Dr. Kilkenny, and along with myself, I assisted him, set up a strategic alliance with the Mountain Health Network, which includes Marshall Health, or excuse me, St. Mary's Hospital, Cabell Huntington Hospital. At that time, HIMG was on board, Valley Health, Marshall University, Marshall Health, Cabell County Emergency Medical Services. We all partnered together to establish our strategic actions. Cabell Huntington actually came online very quick. They purchased a PCR machine that had the ability to test. And we were able to develop the reagents out of Marshall University. So we had a pretty good supply of testing that we could accomplish. However, when the virus started its cycle, and we saw our first large peak just after the July into August timeframe. And I'm not here to give you an opinion on why it happened, how it happened, or anything like that. I'm just going to tell you it happened. I can show it to you. So that first peak hit, and it was a result of, we were quarantined, isolated, not quarantined, excuse me. We were social distance, isolated at home for the first 60 to 90 days. Really wasn't out in the community, and then started opening up very slowly. We started seeing secondary effects of that isolation and people staying at home. Obviously, you have financial difficulties that start to happen. And we decided to open up slowly. So I'm going to pause here for a second because I'm going to ask you all. So when you hear or heard in that July timeframe that we're starting to open back up, what was the message that you received? Somebody help me out. Just tell me the message you received.
Like a literal message or just what we thought?
Yeah, either.
I'll go. My family and I thought it finally was safe to go out of town because we're all vaccinated, even my 12-year-old daughter.
Not in July 2020. Not vaccinated in July 2020.
Oh, 2020. Oh.
Yeah, we're still in 2020.
Oh, I'm sorry. I thought you meant 20. No,
yeah,
we didn't.
Still in 2020.
No, I'm so sorry. No, we didn't trust anything. No, we stayed locked down as a family. No, my daughter was not vaccinated because she was only 11. No, we stayed locked down as a family. We did not travel. We still social distance. We didn't get together with family. We ate out at restaurants, or we would get takeout. We mostly just cooked at home, and which is what we're still doing. We're still cooking more at home. So no, we didn't. No, we didn't trust anything.
Good.
Anyone else?
Someone else. Anyone else?
Anyone else want to chime in? Oh, everyone's muted. You have to unmute. Hit your space bar or unmute yourselves.
Yeah, I can't. I can only see a few people. So
Can you all unmute, or does anyone want to say anything? Diane? I don't know if they can.
okay. All right.
Oh, there's Diane. Wait, there's Diane. Diane, do you have
Go
a?
ahead.
Yeah, I think we thought we were turning a corner, and it wasn't going to be that bad from there on in. We weren't ready to live wildly. We knew enough, but I think the general feeling was, okay, the worst is over. That's what I would hear from others.
Fantastic answer. And I didn't plant you, and I didn't talk before this talk, so that's perfect. That's actually what we thought as well. We was not ready to go back to what we called normal, what we knew as normal, but we thought we were sort of turning the corner. Well, when the first batch of people ran to Myrtle Beach, and then the first batch of people ran to Florida, and then the first batch of people ran to Gatlinburg and Pigeon Forge, the three places anybody from West Virginia goes. The second batch said, well, if they went, I can go. The third batch said, well, if everybody's going to go, then I think we're through this, and everybody ran. Then they brought it back. And in the end of July is when we started seeing a pretty significant peak that caused us some real pain. And it didn't tax the healthcare system significantly, but we did start seeing some issues. So that's what happened. That's kind of what started the first peak. We opened back up, and then you have, so we're sitting here, the other piece of that is we're sitting here in the tri-state area. You've got West Virginia doing one thing, you've got Ohio doing another thing, and you've got Kentucky doing another thing, but everybody is together. The rivers doesn't mean we don't congregate or get together or, stay apart. People work in Kentucky, people work in Ohio, people work in West Virginia, and now we're starting to mix things up a little bit. So that started our first peak. So we started a community testing project around that time. And that's when we pretty much had access to testing supplies. We've done really, really well. And today, the two graphics you see here are our two main sites that we operate. We're operating one on we're not operating it. We have an independent lab operating one on our health department parking lot. And we have one that we collaborate with for Marshall University. And it's over at the old med school site, as we all term it, at 1801, 1601 on that parking lot. And that assists Marshall University in their surveillance testing through the students and the staff there, as well as the community. So that's where we are today. So I'm going to move forward into testing a little bit. And right now we're pretty much open testing. We've got, I don't know, probably 10 to 15 testing sites in the Cabell County, in the city of Huntington. Valley Health is assisting us. Cabell Huntington Hospital has a main tent. These two sites here. We've got one other private medical facility who's doing testing. And then our agency purchased a number of antigen tests, which have now improved significantly to assist us with surveillance. And we also purchased 2 rapid PCR machines. And what we do with those is, and I'm going to tell this story because I'm very proud of it. When we had an outbreak get into a nursing home, this virus tended to go through congregate settings pretty significantly, pretty rapidly, and generally with some bad health outcomes. We had a significant amount of death as a result of that, and it didn't take it long. Early in this pandemic, when we had the ability to test, we had a nursing strike team that we set up that was able to deploy to go to a site to test immediately and try to isolate and quarantine out individuals who happened to test positive. We had a surveillance piece that gave us some information that a nursing home had a couple of positive cases. So we essentially deployed our nursing team to go on site to test every resident as quickly as we possibly could. This is when I was in awe. Our nursing staff was suited, donned and doffed in their personal protective equipment, deployed and testing at a nursing home in 1 hour, no questions asked. At this time, we really didn't know how to combat the virus significantly, other than ensure that these people have their adequate personal protective equipment. And our nurses performed admirably. They were there testing. We found the positive patients. We were able to isolate them, get them out of the general population, and essentially hold that one back a little bit. The problem was that wasn't the only nursing home that was occurring in. It started occurring in more. And it really had an impact on our staff because they're doers. They want to do. And when you're not fast enough, sometimes it feels like you took that responsibility. And their passion is so high that they would assume some of those responsibility. And I will say, and I think we have some medical workers on here, the stress on the medical staff right now is probably at one of the all-time highs. We're losing staff through the quarantines. We're losing staff due to infections, and it's causing a strain on additional staff members. And as I shared at the beginning with Dr. Wilson, it is very, very, very difficult to find a nurse right now. And when our agency started, we had, in about the first 6 months, we had 9 people leave or retire. And it was very difficult to replace those individuals. So our staff had to pull up and grab those responsibilities and keep focused and moving forward. And they did very, very well. So let's move forward a little bit. And the biggest thing that is the issue with this virus is the education piece. I heard a few of you say we didn't trust anybody. We didn't know where to get information. We had to get some information out. And part of that was establishing a call center, which we did. And this was a direct call center specifically to take all calls for COVID-19. To date, we're well over 29,000 calls. And during this time frame I'm talking about, in the summer of 2020 and into the fall of 2020, it was very difficult to get information. If someone had a family member who happened to turn positive, or even worse, a lot of the calls that I was able to take on the after hours, I did all the after hours emergency calls so that the staff could stay focused, is they would have a family member in a nursing home who either tested positive or was around somebody who tested positive, and they really didn't have any, there was nothing they could do. They couldn't go into the home, they couldn't go into the nursing home, they weren't allowed to see their family. It was a very, very, very difficult situation. And they wanted answers, and we tried to provide those answers to them with the tools that we had. So we established this call center real early in the game. And as you can see, we're starting to build an additional staff. We normally run about 40 to 45 staff members in what we call normal operations. When we started the incident command, our staff grew to about 80. One time, I believe we were running 88 employees. That's probably our max. And the only reason we were running 88 is because I could get people to work in this time frame. Right now, it's very difficult to find somebody to take a position. So the call center was established, and that helped with the community education aspect. People just wanted answers. They wanted to talk to somebody. It was very difficult. Physicians were overwhelmed. Hospitals were overwhelmed. Medical offices were overwhelmed. Who do I call? And we set this up. We staffed it. The good thing about it is we were on top of our technology, and our technology allowed our staff to be able to work from home. So we provided them with the technology that they could work from home and operate the call center 5 days a week. So that's something we did. The community education was very critical. We started many social media platforms, Facebook, Instagram, Twitter. We were doing a number of interviews. Dr. Kilkenny, we try to keep him in front of the cameras and the newspapers as much as we can to provide information. Some of our information does go national. Dr. Kilkenny does serve on the board of the National Association of City and County Health Officials. He's the Region 3 representative. So a lot of his information does end up in national print. So we had several educational campaigns that we put together. Right in the middle of this, we've got a specific dedicated public information officer. That's all she does, is take care of all of our public information. She put 2 specific campaigns together that you probably remember, and the names just went right on my head. 1, it's My Shot, and 2, it's not, let's see, I'm going to get this wrong. It's not for it's not for everyone, it's for one another, something like that. I can't remember the exact title she used, but we had about 5 to 6 commercials, a number of print ads, and it was just basically the education that we could provide and give to information during this heightened surge of the pandemic. So now we're moving up into the late fall, and we can see the vaccinations coming. Serve on several committees, and we had several conversations on when it was going to be here, what's going to happen, where we're at, how we're operating. And finally, on December 14th, our first vaccination batch rolled in, and we started vaccinating on December 14th that week. The problem was we only received about 100 vaccinations for a county and city that has 93,000 people. So that created a big issue. So we had to have the vaccination plan very specifically laid out. We had to know where we were going to give them. And a lot of people wanted the vaccination. That was one of our biggest challenges. So we switched the call center to an appointment scheduling campaign and scheduled appointments for those who were, we started at 85 and up, then we dropped to 80, dropped to 75, dropped to 70. I believe when we dropped to 70 wasn't long after we dropped to 60. That was our most vulnerable population, the one whose outcomes were not at where they needed to be. So that started in December 14th, and we moved up into January. Well, we've got 2 issues here. So the one issue is we have to get as many vaccinations into people as we possibly can, as quick as we can. What's the second issue? This is where y'all help me out. Number of vaccines have to go into people's arms as quickly and as efficiently as possible. What's the second issue? somebody has to give the
Yeah,
vaccine.
staffing.
Somebody has to give the vaccine. That's right, Dr. Wilson. So we had to partner with the hospital, and we were tremendously blessed. We had run a non-congregate housing project through FEMA that started on April 14th of 2020. And this significantly pulled a lot of resources away from the hospital and medical system for individuals who were at risk from either homelessness or at risk of contracting the virus. So early in April, if we had an individual who was homeless, who was in the hospital and was positive, your only option was to keep them in the hospital or put them back out on the street. You can't put them back out on the street positive. That's going to create a big issue. So we were able to work with the Cabell Huntington Homeless Coalition and establish a non-congregate housing system where they would take the individuals and house them and isolate and quarantine them for 14 days away from the medical system and just keep them until they were actually over the virus. FEMA came to us and asked us if we was willing to start a community vaccination campaign, which we'd already started. We were already down that road, and they were willing to provide us funding to do that. When they provided us the funding to do that, we immediately said, one, we need more staff, and two, we need a location. So we started with the only location we could do, just to do it quickly, was the Highland, I believe it's the old Highland Baptist Church that St. Mary's Hospital purchased. We were only getting about 100 vaccines a week, so that worked really, really well. However, keep in mind that you have to have individuals to provide the vaccine. So the second thing we have to do is make sure that all of our staff is safe. So when you have a number of people coming in getting vaccines, you had to wait 15 minutes to 30 minutes after your vaccine was provided to ensure that you didn't have any kind of reaction. That created a congregating of people and a huge safety concern. So we could not have enough staff to deliver the vaccine, but then the other piece we had to watch out for is we had to make sure we didn't lose staff due to an exposure or even a possible positive COVID-19 case. So once you do that, at that time, we were quarantining the individuals who were exposed as well as the close contacts for 14 days. So that could put you underwater really, really quick. So what we did, and we were blessed to have this, is we went back to FEMA and said, listen, we have to have staff. And here's our proposal. I've got a medical school, I have a nursing school, and I have a pharmacy school. I need those students on board. And FEMA agreed to allow us to bring medical students, nursing students, and pharmacy students on board to help us run a large-scale vaccination center, as well as financially support a large operation in any place that we could find. And that's how we ended up with the old Sears site at the Huntington Mall. We had a number of individuals, Barberville City Mayor and their town council, the governor, our staff, and many individuals working together to get this site set up. And it literally took us about 14 days. And we started vaccinating at that site towards the end of January. And that really was a game changer in this area, because at that point in time, we could deliver up to somewhere in the neighborhood of 10,000 vaccinations a day. If we had the staff, and we had at one time, we had 300 medical students, pharmacy students, and nursing students at our disposal to go as large as we needed to go. The problem was we weren't getting enough vaccine. We were only getting a limited amount. In this time frame, we expanded to about 2,500, about 2,500 a week. And then it got up a little bit more, about 3,000 a week. And we got up into early March. And that's when we started getting an unlimited supply. And at that time, we were able to vaccinate anybody that wanted to be vaccinated. Not long after that, we had discussions with Marshall Health of putting the vaccination in their medical offices. So their medical providers could have one-on-one conversations with individuals who just wanted more information before they took the vaccination. So those are some things that we did really, really quick, which brought us to this slide here, which you could see the 91,000 people. We've got roughly 53,000 with one dose and 44,000 who are fully vaccinated. We're still vaccinating. That's did decrease a little bit through the summer, but as this last surge has started, we're getting up to where we're well up into the couple of thousand per month. In order for us to change our percentage on what we call the totally vaccinated, we had to vaccinate 1,000 people a month to change it 1%. So those were the markers that we were looking at. If we wanted to go up a percentage point, we had to do 1,000 people. And we still operate that vaccination site today. So here's what you can look at in terms of age group of the individuals who are fully or partially vaccinated. We did get quite a bit in the 51 and above range, not too bad in the 41 to 50, not where we certainly want to be, but then it started waning down pretty low in the 26 to 40 and the 12 to 25 range. So we've still got a lot of work to do. So basically what you can take away from this is we still have about 30,000-ish people in Cabell County who are not vaccinated. And this is a virus that doesn't really care where it goes. It's just going to go at the pace that it needs to go and to the people that it needs to go. So we are hoping that we're starting to see the decline, and I'll show you the decline that we're seeing, that we're moving into an area where we're turning the corner and getting toward an end of this, and then what is going to be our established normal after that. So these are the rates we're running right now. We like to be up around 70%. When you're up around 70%, you can really start to knock the spread of this virus down pretty significantly. These are our cases that we've had and active right now. We were up into the 14 and 1700s real recently. I mean, within the last 10 days. The issue, and one of the things that I want to point out to you that really caused a pretty significant mental and spiritual impact on our staff, was to see these 255 people who pass away. As an agency, we see their names, we know who they are, we know their relatives, we know their friends in the community, and that has an impact on you. I don't care who you are. And it pains our clinical staff significantly when they see one death. And when you see a cumulative death toll of 255 and still going up, it really causes you an issue. And you know, the debate on should I get vaccinated, should I get vaccinated, that's not a group to have that debate with, because they see the secondary effects of this, the primary and secondary effects of this COVID-19 outbreak and pandemic. And this is one of them, and it's pretty significant. We've seen a number of individuals with long-term medical conditions, and that's because our case investigators and our contact tracers, they speak to everybody. If we have a positive case, we make a phone call and do an investigation on that case. And we've investigated every case since we've started. So you can see right here, we've investigated almost 15,000 cases since we've started. And that is a lot of work, a lot of labor intensive work. And it's just basically individuals sitting on phone calls and interviewing people to get who they were around, where they were at, what they were doing, so that we could try to isolate this and knock this down from a case investigation and contact tracing standpoint. So here's what our current dashboard looks like. Our cases have been decreasing up through the end of October. Our vaccination rates are ever so slightly increasing. And our positivity number that we look at is starting to come down. And as you can see, this is up through the about the 18th. I believe we renewed these slides on Monday for the talk today. So we're starting to see about a 7% positivity rate, which is what we look at as a marker. And we were as high as about 10 to 10.5. And that's based on your testing. So we're testing 1,400, 1,500 a day and running about a 10% positivity rate, but we're starting to see the decline happen. And we're watching a model. Harvard started a model across the United States where you could look at each state and each county and determine where the trends are. We started seeing a trend in Arkansas and Missouri about 2 months ago. And what it did, it spread south into Mississippi, Alabama, Florida, Georgia, then came up the coast to South Carolina, Tennessee, North Carolina, Kentucky, Virginia, and then ended up with us. So it really traveled what we call a U-shaped pattern in the Southeast United States. So what we're watching right now is Tennessee and Kentucky. We were watching Florida early, and we're about 7 days behind their change. And that epidemiologic curve, which we have a team of about 5 epidemiologists tracking this, that epidemiology curve is holding pretty consistent. It's slowly improving. If we get done here, I'll try to pull the map up and show you what the map looks like, and you can see the U shape that I'm talking about. So that's where we are as of right now. We're on the downward trend, still quite concerning. Our numbers are still quite concerning, but on the downward trend. So here's the trend that we've seen during time. And this is a pretty telling slide. So the surge that I was talking about after the 4th of July, this is that surge. And man, thought we were really having problems. We thought the challenges were high. Well, as we started to see it, we knocked it down, we started to see it climb back up. This peak of this surge here in December and January and February was 4 times what this peak was. This put an increasing amount of pressure on the healthcare system, the hospitals, ventilators, ICUs, staffing. This one really caused a lot of pain. So we knocked this thing down. We get to July of this year, we were running about 2 to 4 cases a day. We thought we were really doing good. The models looked like we were going to really beat this down into September. And we were going to really move out of this and into normal operations. At this point in time in here, the Delta variant was discovered somewhere around in here. And we started to see this trend mimic this peak right here. Well, as it started to mimic this peak, it started to gain steam and it started to get more vertical than any peak we have. See this little peak right here? This took about a month. This peak right here, you're looking at about a month and a half. This peak right here, you're looking at a little less than a month, and look how vertical is. So we thought we were under a lot of stress and pressure here. We then had a peak that was 4 times what this peak was, then had a peak that went straight up that was twice what our largest peak was. The good thing is this peak went up really quick and it's coming down really quick. However, this time and space in here has put a significant amount of pressure and strain on the healthcare system. The hospital is at max, the ventilators are at max, staffing is short, and rooms and availability were very, very limited. This one put a lot of stress on us, and it's still putting stress on us even though we're in here, but we're starting to get better. So when we look at that peak and we say, wow, we're running cases in the 50 to 60 range a day, that's still pretty high. When you're above 25, most of your resources, with the exception of, or most of your tools, with the exception of vaccine, are very, very limited and do not work at the level that they should. They don't start working your case investigation, your contact tracing. They don't start working until you get down in here, down in the 20s. So you're really, I don't really want to say spinning your wheels, but you're really deploying a lot of information or a lot of resources to try to get this knocked down. So testing is one of our biggest issues here, and compliance with quarantine and isolation is our next biggest step. And that's one of the things that we're fighting right now. Is individuals will do one of 2 things. One, they either won't test, so we can't find the positives, or 2, they'll test and determine they're positive and can't quarantine or can't isolate due to a job, school, college, university, whatever it may be. So that's still creating some stress and pressure on us. I will say that Marshall University has done fantastic. As a school, their surveillance testing, their vaccination rate is close to 80%. and their case count has been very, very, very limited. I mean, very, very, very small numbers at Marshall, and they've been back in school this semester. So this is not a slide that I show that really causes us a lot of issues. So roughly 100 years ago, the Spanish flu went through, and you can kind of see the epidemiologic peaks that it went through. And here we are 100 years later with medical advances that are far significant what was there in 1918. And you see the same flow of the curve. So this is our current curve. This is the 1918 Spanish flu. It's very difficult to compare the two. It's not really comparing apples to apples. However, when you start to see peaks, there are things you can do, but these peaks were sharp in some instances, a little bit longer in others. But this is kind of predicting models that tells us we're going to have a first wave, a second wave, a third wave. Now we're into our fourth wave, and possibly are we going to have a fifth wave? So that's what we're trying to determine with the models right now. This one, I would expect us to be much, much better. You just keep in mind back then, they didn't have a vaccination. They didn't have any really strategy from a pharmaceutical intervention standpoint. So that one was basically isolation, and I'm not sure of their masking capabilities back then. And I'll share with you last year, as we went into the fall, one of our largest fears was that we were going to have the COVID-19 virus, the flu virus, the RSV virus, all coming at us at the same time. And that is what is going to significantly tax your healthcare system, along with other the medical emergencies and medical interventions and surgeries that need to occur. Thankfully, we were on the odd year of RSV. RSV generally peaks every 2 years. We were on the odd year of the down year of the RSV, as well as our flu last year was very, very, very minimal. We really didn't even have a flu season. Masking was pretty strong back then, and we do feel that that contributed to it. Going into this fall, with the peak we have that I just showed you back here, with this peak and heading into flu season, and we're on the second year of RSV, we're starting to see a pretty significant amount of infections, and testing is what's going to help us determine what we're seeing. Is it flu? Is it RSV? Or is it COVID-19? So that is basically a good overview of what we have been through. Many, many, many challenges. We still see challenges. We still see staffing issues. Dr. Wilson, the offer's still out. If your wife wants to work, we've got a position for her. So if you want to run that by her over dinner tonight, I'd be more than thrilled. But one of the issues that we had, and nursing employers were trying to find as many nurses as they possibly can. It drove up the demand. Nurses are getting somewhere in the neighborhood of $150 to $200 an hour to travel right now. So if I offered any of you on here a position to do what you do for $150 to $200 an hour or $50 an hour, many of us would make that decision to travel. And that obviously puts a significant strain on the financial revenue of a hospital. Mountain Health is tremendous, but when they have to start paying nurses $200 an hour, which is 4 times the normal rate, and here we are at the Cowboy Health Department, we're a government agency. I certainly can't pay that. It's been very difficult. I literally right now can't find a nurse. I could use 1 to 2 more. I can't find them. And that has put a lot of strain on us. We're still able to hire some. We do use contracted services, and we've got about, right now, we probably have about 22 to 26 individuals on contract, short-term contract. And that's in addition to our staff right now, we're running about 46. So we're still running about 60 to 70 staff members. And we're going to continue that till we get this thing knocked down and put away. However, I don't have the exact time frame of when that's going to be. The models are telling us that This peak is going to plateau here through the month of October and then start to go down. So we're coming down at a rate we need to, but we're going to plateau before we go down farther. I can't tell you if the models are going to be accurate or not. They've been close, but they certainly didn't predict this last surge. And that's something that hit us hard, hit us quick, hit us fast. And thankfully, we had the partnerships with Mountain Health, Marshall University, Valley Health, HIMG. We had those partnerships already established, and we were still able to fight the good fight, albeit we lost some staff. We had staff go out, so we diminished, as well as we've also partnered with Mountain Health on their monoclonal antibody clinic. So we've got an infusion clinic set up at HIMG, and we actually send them staffing up there to help run that infusion center. So rest assured, if there is an intervention that we can take, we are going to take. And I tune it to this. If your house is on fire and you call the fire department, you don't want to see the fire department pull up and decide whether or not they have the financial ability to fight your fire. And that's the same attitude we take. We're going to fight the fight, and then we're going to figure out how to pay for it as we go or later. And that's my job. That's my role right now. When I sit in incident command, I'm finance and administration. It's my job to figure out how to pay for it and fight the good fight. So the clinical, that team will do exactly what it needs to do. Logistics will do exactly what it needs to do. And then it falls in my lap 2 or 3 weeks after that to figure out how we're going to pay for it. And that's really where we're at. The problem is we are almost 2 years into this now. And that takes a significant toll on your employee and specifically your employee morale. I'm not going to get into the political aspect of what's happening, but that does impact the staff pretty significantly when they're out fighting as hard as they possibly can. And we're working 7 days a week. We're working in the evenings. This virus doesn't take a weekend off. So our staff, as well as myself, sometimes we're on call 7 days a week. And when you run a staff, 7 days a week for a year and a half to 2 years, pretty challenging. It's pretty challenging to keep them focused and keep them motivated. And we've been able to do some things for them. So that has helped. And I will tell you the biggest thing the thing that they gravitate to the most is one little thank you card that comes in, one person who praises them for what they did, one person who pats them on the back when they walk out of the vaccine center, one email as a follow-up. Those things go so far. I've got cards taped in the hallway outside of my office. Every time we receive a card, I tape it up out there. They look at them, they see them. That's what keeps us going. And that's why we do what we do. So with that, Elizabeth, I'm going to stop sharing and I'm going to open it up to any questions. Be happy to answer any question you have or any conversation or comments. I see Dr. Huff's on there. Hello.
Hi there. I just wanted to thank you for the presentation today, but also thank Cabell Huntington Health Department for what they've done. And I've gotten my first 2 shots there. They were great, organized, impressive, and I felt really positive about that. So my questions, though, are how are we doing with the people, the professionals, the nurses, the staff who are on the giving end of giving shots and taking care of people on their immunizations? I know it's sort of become a political issue, which I don't quite get. I mean, you either want to stay alive or you don't. But we've lost some people. We've even lost a doctor recently. What is going on? How well are we doing with that segment of the population?
Not well at all. Very, 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 very challenging. They're lucky to get the 50% for the medical professionals. I don't have an answer for you. I wish I did. We're seeing a lot of nursing homes. So we also, I forgot to mention, we also established a medical outreach team, a vaccine outreach team that actually goes into the community and gives vaccinations. And they'll take one patient. They will actually come to your home. If you are homebound, they will deploy and they'll come to your house. So that team goes out, and what we're seeing, I mentioned the strike team about the testing. We also have vaccination strike teams. And these are teams that go out to specific nursing homes and they'll vaccinate as many staff as they possibly can as quick as they can. They can generally vaccinate somewhere in the neighborhood of 50 to 100 people in an hour. When these people start, they can really make it happen. Nursing homes are pretty easy because the observation time frame is pretty easy to watch those individuals. And we're getting 70 to 80 to 85% of the individuals living in these centers vaccinated, but the staff, we're not getting that kind of rate. We're getting less than 50. And the problem is those are the individuals who go in and out of the facility. And when they go in and out of the facility, the virus comes back with them. So we're still seeing, I think we have about 6 outbreaks right now. And we also have some vaccine breakthrough cases. We're seeing that as well. But that is one challenge that we have not been able to overcome. And you're hearing many situations right now. Mountain Health is establishing a vaccine policy. You're having other medical facilities who are establishing vaccine policies, and we're waiting to see the impact that has.
At this point, could you say what percentage of the Cabell Health staff are actually vaccinated?
Our staff?
Yes.
Oh, we're well above 90. We're in the mid to high 90s.
That's great.
Yep. We were so medical personnel was one of the first group of individuals that we vaccinated in that December timeframe. At that time frame, we received a batch of vaccinations for our staff. The hospitals received a batch. I think they received like 4,000 doses, and we were able to go through the majority of those. But yeah, our staff got vaccinated very early, and actually we're having a good uptake on the booster dose as well for Pfizer.
That was a question I had was, what about the third vaccine and, quote unquote booster? Is that being done at the vaccination center now?
It is. Mm-hmm. Yeah, we've got that. We've actually got the what we call the outreach program. The outreach program is also doing it.
And yeah, and that's, I guess, coming based upon the Pfizer approval, and then of course now the Moderna. But I mean, are you doing Moderna?
Pfizer is already approved, so we've been doing Pfizer for about 3 weeks now, maybe a little longer. I'm not sure exactly on my dates. Moderna is going to be reviewed, I believe, October 26th, and we're watching that very closely. As soon as we get the recommendations, we're vaccinating. We've got the inventory on hand. We've got the staff lined up. We're ready to go. There will not be more than a 24-hour delay from approval to vaccination from us. That's at most, and 24 hours is extensive. I expect it to be the next morning. Once we hear it, it'll be the next morning we're vaccinating.
So if you don't fall in the age range and you don't have an underlying health condition, is there a time frame when, like I got Moderna, when you should get that extra booster shot, we're calling it?
Moderna hasn't been approved, so we don't have any information on that one right now. Pfizer, we're giving it to anybody who's had the shot that is 6 months from their second vaccination.
Okay. All right, that's good to know. 6 months. Yeah.
It's open, and we've got plenty of inventory on hand. We've increased the inventory significantly over the last month, and we'll order exactly what we think we'll need.
What about our daughter is 12 and she got hers, so she's not even due yet. She got her second one June.
6
So
months.
would you recommend it for the younger ones too, the booster, after if they're got 6 months out?
Mhm.
She got Pfizer, my husband got Pfizer, so he could probably, this was February, so if he wanted, he could go get a booster. With this Pfizer.
So I'm not going to point a finger to anybody here, but you have a vaccine expert in this audience, and
We do.
leave it as that.
We do, and that's
I actually got to hear his talk in October.
yes,
And
yes.
I know he'll echo my sentiments. This vaccine is very safe. It is very effective, and our recommendation is you take it.
Well, it was thanks to Dr. Muffson that I had no hesitation. And when it came to our daughter, she turned 12 in April. We did wait a couple months. And I listened to the health experts. I listened to Dr. Muffson, and we were more afraid not to do it than to do it. So we feel good about it. She felt good about it. So do you think, go ahead. Do you have something to say?
Mhm.
Do you think we'll get, so with all these non-vaxxers, will we get to herd immunity, or do we need the people to get vaccinated to beat this?
Be one of the two. Unfortunately, you have a group of individuals out there that feel that if everybody gets sick, we'll move on. I don't agree with that strategy. This virus doesn't pick who gets real bad and who gets no symptoms.
I've heard in the last week or two, I knew one individual, and I heard of 4 or 5 others who were age 40 to 60, unvaccinated, got COVID and didn't make it. And that's, to me, that's heartbreaking. It's heartbreaking to lose anyone, but to an unvaccinated, I don't know. It's heartbreaking. I just heartbreaking.
That tears our staff up. It doesn't matter what age you are. If you're in the age to receive the vaccination and you pass away, I do watch that. That has more impact on our staff than anything else that they do, and it hurts. I'll just say that it hurts. And it's hard to overcome that. You know, as an individual, death does strange things to you. And when you know these individuals and you know there's an intervention, I've seen our staff throw their arms up in the air and just, you know, hey, there's more people out there who need our services and want our services than those who don't. So we've got to work for those people. And that's pretty much the only message I can share with them. There's a group who wants our services and we're going to provide them. And we're going to do the best we can for those who don't want them. We're still going to be here to serve them. We're still going to be here to help them. And we're still going to be here to do what the right thing is in the end.
You know, and you mentioned Marshall, which is of course where I work. And Dr. Gilbert had told me at one time he thought we were 85%, we're 80 to 85. You know, they just made it available for us and they made it easy. They brought it to us. And I guess we all just said, we're going to do this. And we did it in numbers. And I wonder if we've done something, not me personally, but our university, the ones in charge of all this. And I told Dr. Gilbert at one point, I had a chance to speak with him and I praised him. I said, I think you've really, really guided us well through this pandemic. And I wonder if there's anything that Marshall did that others could benefit from to get people to get that higher vaccination rate.
Well, I'm going to give you an opinion. You've got a fantastic leader at that university.
We do, absolutely.
Leadership goes a long way in this situation. And you've got a fantastic leader in Dr. Gilbert. And all the way down to his staff. We deal with Tracy Smith. I talk to Tracy 3 or 4 times a day, and they're phenomenal over there, and have been. And they've even opened it up to conversations. Marshall was one of the first ones to go to masking. That was not a well received. That was not a well received decision. And I can share some other screens here. And you can go see it. Marshall's right now 81% vaccinated, staff and students, employees. So this is their dashboard. You can go review their dashboard, and it's got all their information on there, their cases, case counts.
That's a great student rate.
Yes, it's outstanding. The other thing they're doing is if you're not vaccinated, they're doing surveillance testing on you. So we use the 1801 site to help them with their surveillance testing. So they require you to get tested. I believe it's every week if you're not vaccinated. And that gives us the opportunity to find it and isolate them, get them out of the general student population.
As much as I hate that test, and we had, before the vaccination rates were so high, we had random testing, and we had a lottery and I got called 5 times. And I would take the vaccine not to have to do that test again. Oh my goodness, because it was before the saliva test, and headache. Yeah. So no, I feel very fortunate to work here and to have Dr. Gilbert's leadership. And I felt very safe to be on campus when we returned because of the leadership and the guidance that we're getting with their response to COVID. So I just wish others would, I try to get the message out as best I can. And I know, thankfully for Dr. Muffson, he is still an amazing resource. And anyone else have anything to add or say or ask?
Yeah, he gave us such a good at the front end of this. I remember his good overview for us to help us. Thank you, Dr. Winston. Wasn't Becky trying to say something earlier, Rebecca?
Becky, do you have something to say? You can unmute.
Oh, I thought I saw her.
Elizabeth, I'd like to ask a question.
Sure, please.
A word of thanks, Adam McDermott at the Health Department was very helpful to our community. I live at Wingate Condominiums. He helped a lot with our swimming pool guidelines this summer, and also with like community meals and things along that line. He provided several documents, and anytime we had a question, he was very responsive. So a word of thanks to Adam.
I'll read that to Adam. Adam's on our environmental team, yes.
Yes, and but a question, has the CDC revised guidelines for like community meals inside? We were basically discouraged from doing any kind of potluck where people brought in food and we all touched the same spoons and
Yeah.
that kind of event where it was indoors. And I just wondered if there's been any revision to the guidelines that we received back in, I think it was May.
Yes, there has been. So there's a couple things that we're seeing. Our epidemiologic team, they watch this very, very closely. And it's really interesting. We're not seeing a lot of transmission from that perspective, foodborne or touching or even outdoors. So when we started high school football games and we started college football games, we just cringed at the neck. You know, that we know what's going to happen, we know what's coming, and we're going to have to keep fighting with less resources than we had at the last surge, and try to focus on how we're going to stop this surge with that going on around us. We haven't had that. What we're seeing with this variant is it pretty much gets into what we call a congregate setting, a household, a nursing home, a facility where people are congregated or living together. And that's where we're seeing a lot of our issues. It's still significant community transmission, but outdoors, we're not seeing a lot of problems. Restaurants have not caused us a lot of problems. So there is some relaxing on it. However, we still recommend you do it safely. You know, if I happen to also provide some guidance to a couple of camps, and what we share with them is, you know, if you could do a buffet style dinner or a potluck style dinner, individual goes up, they should have their mask on, they should limit the spoon, don't let the spoon drop in, you know, maybe keep the utensils outside of the food. Someone should maybe come through and wipe them off every few minutes. Should use hand sanitizer before you go, wash your hands real good, and then try to move through the line. If we do that, we tend to do pretty good. As Elizabeth shared, I'm a member of the Huntington Rotary. We've been meeting, we started meeting in August and we continue to meet. One, we're in a large, well-ventilated room. Two, we stay apart from each other. So we have round tables. We only allow 2 people sit at a table. We don't congregate at the door. We don't tend to mingle. We come in, we socialize where we can, and we hear the speech and we get our food and we leave. They're serving our food right now, but there have been some guidelines relaxed. The issue is when you have a community meal like that, people tend to get together and they congregate. And that's the thing that causes more problems than the food. I've seen it happen a number of times. I was just in a meeting here about a week ago. Everybody walked inside the door and then nobody moved. Well, there's everybody standing right inside the door. Move through the door, get to your seat, and let's get separated. And a lot of times these things can occur. We've provided guidance to many churches.
That's what I'll say. That's our church syndrome.
Many churches. We want to keep the spirituality aspect moving. Isolating people is not the best thing to do for people's mental health, spiritual health, and emotional health. You start seeing secondary effects when that happens. So allowing people not to attend a worship service is very difficult. But there's ways you can do it. And if you do it the right way, it is safer. It's not safe, it's safer. And that's what we tell people about the meals. We can make them safer, but I can't make them safe.
Thank you.
What I have on here, this is one of the models that we've used. This gives you every county in the United States. And here is that swing that I was talking about. So we're right now starting to see the line get into Kentucky and Tennessee, a little bit in South Carolina. It's going to keep moving this direction. So we're about 5 to 7 days behind this swing. When we started watching it, Florida was running about 100 daily cases per 100,000 per day, and they're down to probably they're running about 14 right now. So the virus hit hard, but it came this way. So literally about 2 weeks ago, Florida was was above 100, and now they're at 14. Kentucky and Tennessee is what we're watching. So Tennessee's running about 25 right now. Kentucky's probably a little bit higher. West Virginia as a state's running about 57. Cabal's in the 40s. We're a little bit ahead of the state. There's Kentucky. Kentucky's running about 39. So the trends are still going in the right direction. These are still high numbers. You don't really start getting comfortable until you get down in here, down in the 8s, below 10. These are still high numbers, even though you say, wow, that looks great. That's just basically comparing those numbers to this graph. 20 looks better than 160 or 170, but 25 is still high. So when we're in the 25 range, you can see we've spent about half of the year under 25 and about half of the year over 25.
I had a question.
Sure.
First, I'd like to echo what Diane said. We do appreciate all the things you've done in the last year or so. Nobody expected this, and I'm sure that it's been a struggle for us, and I can just imagine what it's been like for you all. But my question was the antibody infusions that they're giving people once they do have it. That may be more the hospitals, but is that limited to people considered high risk?
It was when they started, and they've opened it up more. But what you have to do is you have to get a referral from your physician.
Yeah.
And that's generally what we're seeing and the way we're running it. There was at one time a semi-shortage of the monoclonal antibodies. The hospital is very good about sourcing this out, and I'm going to throw a big shout out to Mountain Health. When the monoclonal antibodies came out initially, and I can't say their names without bungling them somehow, bamlanivimab, I believe I'm close. When they came out, they were starting to look at how to set up an infusion center in several sites across the United States. We had already talked about it. The leadership at Mountain Health had already established a way, and I'm going to give a shout out to Dr. Larry Dow and Dr. Carol Willenberg. They had already established how to do this, and we're doing it long before the United States started doing it as a whole. And we really started moving in that direction. But right now, yes, you have to go through your provider, but it's generally, I think you have to have the virus 1 to 5 days. And I'm not a clinical person by no stretch of the imagination, but they will provide you the monoclonal antibodies if needed. And they actually had a conversation with Dr. Dow yesterday, and we're looking for Dr. Willenberg to determine the follow-up. And right now they look at the follow-up pretty much. It's very, very strong and very, very positive. It will shorten your symptoms and shorten your duration of illness. It's been very strong, but I have to commend that team because they set up that infusion center really, really quick. And also I have to throw Dr. Kevin Yingling in as well. Dr. Yingling is not only a medical doctor, he's also a pharmacist and dean of the Marshall University Med School previous. He knows exactly how these things work. and he assisted as well. So that whole team over there set this infusion center up really quickly. And that was another tool we had in the toolbox that we could utilize.
Yeah, thank you.
Welcome. Thanks. Good question.
There's still, had we had all the people who didn't take the vaccine take it, we could have reached herd immunity of 80% much more quickly.
Absolutely.
And we would have cut down the importance of I think, the Delta variant in the community. If there are few people to spread it to, it slows down.
Absolutely.
What I can't understand is, no one dies from the vaccine. And I can't understand why we have a nationwide anti-vaxxer campaign, because that's going to lead, I think, to bad things when we begin looking at other vaccines.
Mm-hmm.
And vaccines have saved more lives since we began vaccines in the modern era than any other means of keeping people well. So now I think the epidemic is mainly among unvaccinated people.
Mm-hmm. Yep. Yeah, you can look at the statistics at the hospital and you can see the impact of vaccinated and unvaccinated people. We can't say that the unvaccinated people won't get it, but the message, and I totally agree with you. You're exactly right. This thing is just tearing like wildfire through unvaccinated individuals. And the anti-vax campaign, they will find, and you're the absolute expert to this, they'll find one article from one physician who supports their view, and it is very difficult as a medical and scientific community to overcome that article. You have to start a whole campaign to override that one written article that fits the media or fits their agenda. And it's really causing us a lot of pain and problems, and the financial impact is just it's just outrageous.
The pandemic is a pandemic now of misinformation.
Mm-hmm.
When I was at the NIH in the early 1960s, my lab chief said that if there's one bad article in the literature, it takes 200 good articles to change people's mind about the one bad article. And that still holds.
Mm. And look at that, Dr. Musselman, in relation to what social media has done, even accelerating that. That's Tim, could I ask a question? And I don't want to. It comes with probably a political undertone, but since during this period of time, our legislature decided to join the bandwagon in the misinformation and cause this issue between public health and government entities to kind of clamp down, to say, well, if you all mandate something, or if you decide something from a public health standpoint, the governmental officials can, have to get involved somehow. I guess mine's a question of the admiration that I have for Cabell Huntington Health Department. Are you all creating a good relationship governmental wise with our entities? Do you get what I'm asking?
Yes, great question, Dr. Wilson. And the short answer is absolutely 100%. We are going to base all of our information and decisions on clinical science.
Mm-hmm.
We're going to base all of our information and decisions on credible authorities.
Mm-hmm.
And we're going to provide you guidance. If you elect to do something different, we're not going to support you. We're not going to go out and do a campaign to derail you either. We're going to provide you sound guidance, and you take that with what you want. But when it comes down to somebody asking us an opinion, we won't provide it. We provide them guidance based on science, credible science, data. And that's how we've done it. That's how we do it. Like I say, Dr. Kilkenny is an incredible physician as well as a scientist, medical scientist, and we've got a team of epidemiologists. And if you don't agree with what we're putting out, I can't change that. But
Mhm.
we're not going to change our stance in how we're going to protect this community from a public health standpoint. So we've got several agencies who came to us. What do you recommend? We recommend you put a mask policy in place. We're not going to do it. That's fine. We'll respect your decision, but we
Mhm.
will not support your decision. We'll simply respect it. But as I said earlier, there are a number of groups of people who want our services and want our input, and we'll provide it. And we'll provide it. There's no hard feelings. It's not
Mhm.
personal. But I can't bend what we see,
Mm.
and we see it. I mean, when I show you this graph, you can say what you want. When you see this graph, there's not a thing in the world I can do to change it. And I wish I was smart enough to manipulate it. Some people say we are. I can't manipulate that. That's case count. This graph right here comes from data that 1,000 people had input in. I can't manipulate it, but I can say there's our case count, there's our surge, there's what we're seeing, that's what we're fighting, and that's the resources that we're putting to fight this. The other thing I'll do is it's very exhausting to fight an argument that you're wrong. We just won't do it. We don't have the time. If our staff starts fighting that fight, we're going to be out in 30 days. None of us can handle that.
Yeah.
Emotionally,
That just,
physically, spiritually, physically.
that just depletes the energy.
It does. And we just don't do it. And that's how our staff stays focused. The things we see in-house are not the things that the community sees or reads. And it guides our interventions.
Mhm. Thank you. Thank you.
Welcome. Great question.
Any other comments?
Wonderful discussion. A wonderful discussion. I'm thoroughly appreciative of all of you.
So I have a quick question. I know that the Delta took over, and I did read that in India, it had a quick incline and a sharp decline, and we're kind of seeing that, right?
Mhm.
But because we still have so many unvaccinated, will this virus continue to mutate into something else? Are we still in jeopardy of another Delta type something? And, you know,
As
on and
long
on.
as there is host to infect, this virus is going to infect.
But it will change. And then, which I think is more serious, because then it's a different variant and you've got to find science has got to get on that to try to counteract that.
Let's hope that it mutates and makes its genetic code kill itself.
Can that happen? I mean, I don't know, Dr. Muffson.
I hope it would. I mean,
Is there a light at the?
That's a poor strategy, but it certainly makes you smile.
But is there a light at the end of the tunnel? Like you said, we're going on 2 years in March.
It's difficult to say. I asked a medical professional just the other day, you know, how long did it take to where we stopped seeing the Spanish flu? And the comment was, we're still seeing the Spanish flu today. That's 1918. So at some point, this is probably going to become endemic, as Dr. Muffson shared. We're going to reach herd immunity somehow, some way, one way or another. We're going to get there. It's either going to be through vaccinations, or it's going to be through contracting the virus and having the natural antibodies to help fight it. We'll get there somehow, but as long as we have unvaccinated individuals or individuals who do not have antibodies in their system, this virus is just going to keep burning.
Well, and there's a cavalier attitude, I think, among the younger generation, and I'm not trying to pick on them, but I was at a paint store the other day making a purchase. I had a mask on, I'm vaccinated. And the young gal that helped me, she said, "Oh, I'm not vaccinated. I had COVID. It was no big deal." Oh, okay, great. Good for her that she didn't get very sick. But I'm like, oh, I don't really want to be close to you. She said it was just a couple of weeks ago. And we kind of have a policy at our house, and I don't know, others can chime in. I will not go around individuals that are not vaccinated. We had a party this weekend for our 2 nephews, and my sister-in-law put it together, and it was outside at the Harveytown Park, which is really nice if anyone needs a really nice outside venue. It was beautiful, clean, nice. and she only had vaccinated. Of course, the little ones can't be vaccinated yet, but the adults, she only had those of us who are vaccinated. And that's kind of my policy right now. Like, you can infect me, I can get it, breakthrough. I might not get real sick, but I'm going to have to miss work. I'm going to have to quarantine. So that's just kind of how I'm rolling with it right now.
Can't make it safe for you. I
Pardon me?
can make it safer.
Yeah.
And
I think
that's,
that's-
we have since day one, we've been saying that. I can't make it safe. I can't make it safe
No.
that we could all got in a room and sat down and had a meal and talked. If you wanted to do that, there's a safer way to do it. Ventilation, high ceilings, stay away from each other, social distance the best you can, eat, finish eating, put your mask back on, wear your mask when you're moving around, don't congregate at the door, use hand sanitizer. There's a lot of tools in the toolbox, but unfortunately people just don't want to use them. And I get it.
Are you surprised with, you mentioned the football games, that we haven't had a big outbreak? Because people are really kind of close together and they're not masking. So we're not going to football games, but it's turned out pretty okay. It seems like to go to I'm still not going to go, but.
Tremendous win there. And we don't
Okay.
know why, but we're not seeing it. So we generally would see the problem 5 days after the event. So I can go back and I can show you July the 4th, the next week we had a spike. Labor Day, next week we had a spike. Thanksgiving, next week we had a spike. Christmas, next week we had a spike. I mean, you can go back and see it. And then they said, well, we're all going to go back and we're going to have football games and we're going to let the fans back in. We're not going to limit the numbers. Oh gosh, here we go. Every Wednesday is going to be a nightmare. Hasn't happened. I don't have a reason why.
Like you said, outdoor, the high ceiling, wind, all of it. That's
Don't
good.
have a reason why.
Yeah, well,
It really, outdoor activity really has not caused us problems. And now we guide people on that. We'll say, if you can have your event outdoors, it is safer.
any other questions or comments before we let before we let Tim go? Because this has been really, you've just taken what Dr. Muffson shared with us and given us the data to strengthen his talk.
Our team watches that data every day.
This is Jane McKee. I just wanted to say that our health department is amazing. And I thank you so much. I have had both vaccinations and my booster. It has been so professional, so easy, and so, I mean, they're just kind to you. And I thank you all very, very much.
So I'm going to share something there with you. And this is really interesting that you say that, and very, very, very promising. So the individual who runs that vaccine center is a graduate of the Marshall University School of Pharmacy very recently. The individuals working in that vaccine are our future healthcare professionals. We've got med students up there, we've got nursing students up there, and we've got pharmacy students up there. That is very encouraging and very, very complimentary to our professional school here at Marshall University. That one goes a long way, because that's going to be the next 40 years of our healthcare system.
Right.
We have anything else to add or say before we've got 3 minutes before we let him go?
Yes, many thanks for a great presentation with a lot of updated data that
Thank you.
is somewhat comforting.
Thank you.
All right, well, with that, I'm going to thank Tim again for being here. It was
Sure,
really, really, really informative. Thank you so much.
And I am happy to come back anytime. We'll have to find another topic. Maybe we'll talk about TB.
Okay, if there's a topic, if there's a topic you want to
I got
share
an
with
expert
us.
here. I got another expert that can help. Elizabeth, thank you for the invitation. I really just appreciate having the conversation. It is actually therapeutic for us to have a good conversation like this.
Well, good. And thank you for really, to echo everyone's sentiment, thank you for what you're doing for us. You are working the extra hours, the weekends, the on-call to keep us safe. And we're just, I know we're all appreciative. Thank you. Thank you so much.
Thank you.
All right. We'll talk again soon. Thank you.
Thank you.